Our speaker today is Paul Burbage. He's one of our Studio 3 trainers and practitioners, and he's got a lot of experience in the area of self-injury, which is what we'll be talking about today. So we'll be speaking for about an hour about supporting individuals who self-injure using a low arousal approach. So thank you for joining us today, Paul, and I'll hand over to you now.
Brilliant. Thanks very much, Rachel. Appreciate it. Thank you. Good morning, good afternoon, good day to wherever you might be joining us from. I think we've got quite a few people from around the world, North America, some people down in Australia, across the UK, and some parts of Europe as well too. So welcome along. Thank you very much for joining me today. It is the evening over here in the UK. It's around 5 o'clock, so it's not too bad there, but things are getting a bit dark outside. So today we'll be talking about self-injurious behaviour. We have a few slides there, so just bear with me and I shall bring them up for us today. Brilliant. Okay, self-injury, a low arousal approach is what I'll be looking at today. And now it doesn't give us a lot of time to sort of talk about a lot of things in depth there. We've got the Q&A button, as Rachel sort of said. So if you have any questions, pop them on there as well too. If you have any questions that maybe you don't want to discuss on the webinar here today, or that might be sort of a bit more complex or in depth, or something that you want to sort of keep a bit quieter or private, by all means, you can email us on Studio 3, admin at studio3 there.org. And myself or one of my colleagues will be able to come back to you as well to just put it as a subject heading, self-injurious behaviour or SIB query from the webinar. Okay, so today very much supporting children and young people who self-injure using some of the low arousal approaches today. And we're going to use and talk about a bit of a wellbeing approach. And as I said, we've sort of covered quite a range of things today, and we'll have a look at a few bits and pieces as we go through as well. So a bit of difference between self-injury and self-harm, a distinction between the two. There is sort of a bit of argument and a sort of discussion between what is self-harm and what self-injury. Is there a difference between the two? For myself as a practitioner, I'm thinking more self-harm is, to me, examples like sort of cutting would sort of be more described as something that's is sort of organised, it's sort of premeditated in a way, organised, and then there's a time and a place where that may happen. It may have a set of implements or instruments, equipment that's associated with it. So there would be the implement that was maybe used for cutting. There'd be care wound or sort of self-care wound equipment and items afterwards. So that could be things along the lines of antiseptic wipes. It could be bandages or band-aids. It's fairly discreet and it's sort of hidden away, and it's sort of very much a more controlled sort of behaviour. The sort of one we'll be talking about in self-injurious behaviour is that one there, that any behaviour initiated by the individual which directly results in physical harm to that individual. Physical harm can include bruising, lacerations, bleeding, bone fractures and breakages, and other sorts of tissue damage as well too. So some of the types of self-injury I might be talking about here are things like head banging, banging against hard objects, sharp objects, so the corners of walls or door frames, against walls, against doors as well too. Head banging can also be against another person, or windows and so forth as well too. Hand or arm biting, typically sort of characterised by having those sorts of large calluses around the hand area, sort of thing from biting. Generally sort of a thickened area of skin, maybe some bleeding or skin breakage, but generally has that sort of thick padding that is there. Hair, teeth, fingernail pulling, so that could be hair on the head. It could be eyelashes, eyebrows as well too. Hair on arms and legs. Teeth is a bit on the rarer side, but I have actually seen that as well too with one particular individual I have worked with. Of teeth being removed, and that was a very much an isolated incident in that case. Fingernail pulling, eye gouging or poking is some other behaviours that we've sort of come across and can be quite common with self-injury. Face or head slapping and punching is probably the most common form of self-injurious behaviour that we might be working with and trying to manage as well too. And that can be from very low level up to sort of quite high level where there is substantial sort of significant damage, either to the cranial area, to bone, to eye sockets. It can also include sort of, the build-up of callous sort of bone structures as well too from that. You could also have the other consideration worrying about sort of detached retinas as well too, from that sort of head, face slapping and around that sort of eye orbital sockets. Skin picking, scratching and pinching, forceful head shaking, dislocation of joints, again, slightly rarer to sort of see. Picker, that persistent sort of eating of sort of substances that aren't food or aren't considered sort of food items, and excessive rubbing of causing sort of tissue damage. So, yeah, excessive rubbing on the hands, on the legs, elbows, upper arms as well too, around the face area, sometimes across the nose and the mouth as well too. So just a few examples of the type of self-injury behaviour that we'll be talking about. The nature of self-injury can be quite varied as well too. So self-injurious behaviour can often be kind of episodic in nature. So it might be there present for a short burst, for a period of time, and then it seems to go away. It may come again later on, or it may not actually re-emerge. We find sometimes self-injurious behaviour can be more prevalent in early years, children and young people, but as they get sort of older into adulthood and into sort of later 20s and 30s, that some of that self-injurious behaviour can actually decrease, both in intensity, frequency and duration as well too. Self-injurious behaviour can also be stereotypic, so a sort of behaviour that produces its own effect of being like in a flow state, or sort of is happening, but it's kind of regular. It provides some sort of soothing or regulating type feedback, but once started, maybe sometimes quite difficult to actually stop as well too. Ritualized routine sorts of self-injury. So that may be part of a larger side of being able to sort of transition or to move from one thing to another. It could also be ritualized or part of a routine to be able to sort of finish one task and move on to the other, or to actually start a new task as well too. Self-injurious behaviour can be regulating in nature, so a form of self-regulation and quite sort of soothing. It can also be a form of communication, but also it could be a source of being able to get sensory feedback or to sort of meet a sensory purpose as well too. So these are just some of the examples and some of the areas that the nature of self-injury can actually present in. Individuals with a severe, profound degree of intellectual disability have been found to be quite significantly more likely to engage in self-injurious behaviour and stereotyped behaviour than individuals with a mild to moderate degree of intellectual disability. And research has sort of shown that that's the case, that there is actually quite a connection between some learning developmental difficulties, intellectual disabilities, neurodevelopmental disorders as well too, and also the comorbidity. So the more of those sorts of diagnosis, more than one, the more likely it is that that person may present with self-injurious behaviour. So what we've also found is that individuals that have got difficulties in either sort of receptive communication or being able to express communication, so that's being able to understand as well as to be understood, are significantly more likely to show self-injurious behaviour. And we also found that there's quite high rates of self-injurious behaviour being reported in people with a diagnosis of autism spectrum disorder as well. Prevalence, self-injurious behaviour has been estimated to be around sort of 1.7% for people with disabilities in non-residential environments. They're the latest sort of, figures from about 1986 there. It has sort of, ebbed and flowed, but it's generally still pretty much a common sort of figure of around sort of 1.7% for people with disabilities in non-residential type environments who present with self-injurious behaviour. It is more common in people with autism spectrum disorder and quite common in people who also have a learning disability as well, and also quite common when you've got those comorbidities together. We've also found that some syndromes or certain medical conditions can also indicate an increased risk factor for the presentation of self-injurious behaviour. So Leschnian syndrome is quite a rare inherited disorder caused by an enzyme deficiency. And that can also present symptomology with that sort of finger biting, lip biting, and or head banging as well too. Rett syndrome, again, has been associated with being on the autism spectrum disorder, a disorder that affects brain development and progressive loss of motor skills and language. And that's been has been noted as also having a high prevalence of self-injurious behaviour associated with Cornelia-de-Lange syndrome as well too. For causation, though, despite sort of conditions and certain sort of diagnosis that may actually sort of indicate a higher risk factor, there is no one sort of theory that significantly explains and defines the causes of self-induced behaviour in all cases. So there's no one-size-fits-all sort of explanation, and there's no one-size-fits-all sort of reason or rationale for why someone might present with self-injurious behaviour. So it recognises that the causes and the sort of triggers to self-injurious behaviour will actually vary across the population and across from one person to another. Behavioural models suggest that behaviour may be reinforced by some of the external sources of positive reinforcement, such as gaining attention when they engage in self-injurious behaviour. It could be negative reinforcement, so maybe there's negative stimuli in the environment may cause the behaviour. So maybe unpleasant or adverse noise or overly noisy sorts of environments as well too. It may actually be the result of escaping from demands and requests. So demands and requests placed by other people, generally staff or carers, may actually be the trigger for self-injurious behaviour. A demand or request is made, self-injurious behaviour results from that. The demands and requests are dropped, and that might be the reinforcing thing, that I engage in self-injurious behaviour and those demands and requests are dropped, and I'm no longer have to meet those demands and requests, or at least try to process them and do what's being asked of me. That behaviour may also produce some sort of intrinsic, so internal reinforcement. So I might be getting some sensory stimulation from self-injurious behaviour, or it could actually be a part of pain reduction as well too. So we could be talking about sort of maybe referred pain to another part of the body. It could be the sort of the serotonins and the natural painkiller feedback that I get from engaging in self-injurious behaviour that actually helps to deaden or to sort of dull the experiences of pain in another part of my body as well. And that kind of sort of makes you think about what other sorts of medical conditions may actually be associated with self-injurious behaviour, which we'll come to shortly. Self-injurious behaviour sometimes has a communicative function. So for, as I said before, some individuals that have difficulties expressing or being able to sort of receive, understand communication from others or with others, it may serve as a communication function. We all know that all behaviour is communication. Not all communication is behaviour, but all behaviour is communication. It is communicating something, somebody's needs or somebody's requests or difficulties, things that might be missing, difficulties with regulation, difficulties with coping as well too. I think one of the biggest things that we do need to sort of recognise, and I'll come back to this towards the end, is self-injurious behaviour itself really does evoke strong emotional responses from carers. It's one sort of area when you're trying to manage maybe some of those complex, difficult signs of stress and distress, that when those behaviours are externalised, whether that's through language, that's through movement, that's through the fight or flight response, whether it's verbal or physical fight, whether it's through property damage, those externalising sides, sort of presentations of behaviour that indicate someone's become distressed or dysregulated in some way, they can be difficult to manage. They can be very difficult to sort of work with at times. There may be significant risk with some of those behaviours, a risk of harm to that person or to other people, or members of the public as well too. However, when it comes to sort of witnessing and being present when self-injurious behaviour occurs, that causes quite a lot of distress to carers, to staff, because it's one thing to try and manage those other behaviours. It's another thing to actually watch someone becoming so distressed or so upset that they're actually hurting themselves. And it does create that sense that for staff, they want to intervene, they need to intervene, they want to stop that person from hitting themselves. And it causes a lot of distress for for those carers that are caring for people that engage in self-injurious behaviour. And that's something that I think, one, needs to be recognised, and two, it really does feed into staff working with individuals that do present with significant or high intense levels of self-injurious behaviour, to make sure that they're actually being looked after as well too. There will be a trauma and a stress impact on those individuals who are caring for and supporting people who engage in self-injurious behaviour. Self-injurious behaviour itself as a term can be quite sort of misleading, because we know that the function or the functions of such behaviours can vary quite a lot from one individual to another. but also the terms of that self-injurious behaviour kind of says that, in a way, it kind of intimates that that person is actually doing so to hurt themselves. They're doing it on purpose. They're purposely causing self-injury to themselves. Whereas self-injurious behaviour, the behaviour itself and how it presents, is more around meeting needs, unmet needs, stress, distress, the communicative sort of function that goes with it. And as we said before, there's quite a lot of different possibilities of what's causing that behaviour. So to actually sort of think about it as just the behaviour itself, as this person's doing it to themselves, really doesn't recognise why that's happening. Why is that person engaging in that sort of behaviour as well? There does seem to be a relationship between self-injurious behaviour and stereotyped behaviour. Both of them can be quite sort of regulating in function. So we're looking at the functional side of things. And that we have found that with stereotyped behaviour, if you try to reduce that sort of stereotyped behaviour, that sort of maybe that rocking or that stimming sort of behaviour, it can actually lead onto the presentation of self-injurious behaviour, or where it's already presented, lead to an increase in self-injurious behaviour. And again, what we found is that to reduce maybe self-injurious behaviour, we've got to be able to tolerate and be able to manage a lot of stereotyped behaviours instead. So you'll find that the reduction of one behaviour can lead to an increase in the other. We've found, and made quite a lot of sort of advances in being able to understand the causes and the functions of self-injurious behaviour, but we are early, only sort of just starting to begin that sort of journey. There's still a lot of work to do. And as you'll sort of see is that the self-injurious behaviour itself is quite a complex behaviour, not just to try and understand, but also to manage as well too. So where that comes from, but also how to manage some of that behaviour is also quite complex in return. When it comes to behaviour management, we have recognised there's quite a few sort of issues that come with that. First of all, the extinction burst. So when we employ a behavioural intervention, particularly if it's one that's trying to sort of change that self-injurious behaviour, what we will find is that during that change process, some of those behaviours will get worse before they get better, the extinction burst. What we also have seen as well too is that sometimes that self-injurious behaviour may present as further aggression that individual puts onto themselves or externalizes around them into the environment and the people in that environment around them. So that's the elicited aggression, okay? Both are sort of side effects of any sort of behavioural interventions, and it's recognised as such. What that essentially means, though, is that if you're looking to sort of change a behaviour, you're going to need to be able to manage it first anyway. But because those behaviours will get worse before they get better, and other behaviours may actually present, you're still going to need to be able to manage those behaviours and actually manage them better than before you started any sort of interventions. Much of the literature that we do find around sort of, behavioural interventions based around sort of change rather than management has tended to sort of focus very much on the positive side of things, okay? So we tend to sort of see the things that work or those instances, those cases where there has been a positive outcome in reduction of the frequency, the intensity, or the duration of those self-injurious behaviours, or in some cases where it's been pretty much almost sort of brought to a stop and that other behaviours have actually sort of taken place. There's a lot anecdotally to sort of say that a lot of those sorts of interventions will reduce, in some cases, some of those behaviours, self-injurious behaviours, the frequency maybe, or maybe the intensity, but we won't have as many of the positive outcomes as what you will see in literature. A lot of the behaviour management strategies are really poorly understood. So sometimes we struggle to actually find out what to really be able to say categorically, why did that behaviour management strategy work? It could be from a range of different sorts of other unplanned for or sort of unexpected outcomes that will actually result in that change in frequency, in duration, or intensity of those self-injurious behaviour as well too. What we'll need to do, though, is, as I said before, to be able to manage those behaviours while we're doing the change, which means that those management strategies need to be really, really quite effective to be able to get us through as carers through that sort of change process. A lot of evidence that we have got is that self-injurious behaviour also can be maintained by environmental events, such as the need to sort of have social interaction or to maybe avoid social interaction. So we might find that self-injurious behaviour occurs because that person isn't getting the interaction and the engagement from others that they're looking for. They're engaging in self-injurious behaviour, not as a way of getting that attention, but as a result of being distressed, of looking for that, the sort of the non-engagement and the impact that that may have may actually create high levels of stress that that person regulates with or presents or communicates in their behaviour with self-injurious behaviour. They engage in that behaviour, carers stop what they're doing and engage or interact with that person. And if over time that sort of tends to be regularly the case and it tends to reinforce, what you will find is that person will engage in self-injurious behaviour to be able to get that interaction from others, okay? It could also be the opposite. It could be the avoidance of that social interaction. So the difficulty of being having to engage or interact with others. It could be because of the demands and requests that are being made, the things that are being said, how they're being said as well. So what type of engagement and interaction may actually not be positive. It may be quite aversive for that person, or it's not something that they don't enjoy and don't want to do. And as a result, it could be those activities as well. And as a result, the avoidance of that social interaction may actually result from engaging in self-injurious behaviour. So that means then that might be what caused that self-injurious behaviour to sort of develop, and that sometimes is maintained that. So those are internal events as well too, where the sensory feedback I'm getting, or it's the reduction in engagement from others, pardon me, means that that self-injurious behaviour is reinforced. Sensory stimulatory approaches to managing self-injurious behaviour may therefore help to distract people. So we could be looking at what sort of sensory profile that person has. As a result of that, we know what sensory stimuli is positive for that person, or which has a positive outcome and a positive effect. And then from that, we create a sensory menu. And that sensory menu might be actually the thing that works as a distraction or diversion at those times of crisis when that person is maybe getting towards that point of engaging in self-injurious behaviour, or they have begun engaging in self-injurious behaviour as well too. And we found there's actually quite a lot of clinical evidence that actually supports this. One example there is that YouTube clip. It's called Handling Self-Injurious Behaviour in Autism. And it's a short clip of mum sort of using a handheld vibrator that slips inside of a hand mitt. She puts that hand mitt over her son's hand, and it's that sensation of the vibration against his hand that he finds quite sort of, therapeutic. It's quite a positive stimulation that he's getting from that. And as a result, it reduces him, the incidence of him engaging in self-injurious behaviour when he actually starts that. Temple Grandin, she herself has sort of reported that at times she needs to feel that deep pressure contact. So there's a sensory feedback for herself. And she says that feels quite calming on her. And in fact, it's one of the things that she uses in her research and in her work in cattle ranches across America to actually create sort of, the cattle yards and the cattle slips that provides that reassurance and that calming effect for cattle moving through those sorts of processing works. She uses the same sort of thing then, that sort of the crush, the feeling of that sort of all over pressure to be able to sort of have a calming effect on the cattle. And she got that from herself. But she will also say sometimes that physical contact can be quite painful to experience, and particularly if it's that light touch as well too. So deep pressure contact can be quite calming and reassuring, and at other times physical contact or light physical contact can actually be quite aversive for her. So sometimes what we might find is that some people may engage in self-injurious behaviour because of what's happening in the environment around them. But once they've actually started, they're unable to stop. So they might actually get themselves sort of, into that rhythm of engaging in self-injurious behaviour, get whatever feedback that might be or whatever reinforcement that is provided from it. However, once they're started, they're really struggling to stop. And the stress of being unable to stop sort of feeds into the continuation of that self-injurious behaviour as well. In behavioural psychology, it's long been accepted that whatever reinforces a behaviour in the beginning may not actually be the same thing that actually maintains that behaviour going forward. So what we might have is that the initial behaviour met a need. It could be a sensory need. It could be that avoidance need. However, that contingency reinforcer for the self-injurious behaviour to continue may not actually be there. It may become a stereotyped behaviour. So that sense of sort of repetitiveness or that flow state that's accessed through stereotype sort of behaviours is based around that self-injurious behaviour continuing. So there's a different sort of feedback that they might be getting from that. So that's where we're kind of talking about that the self-injurious behaviour met an initial need, but it also had another possibly non-contingent feedback or sort of reinforcement from that. And as a result, then it becomes the thing that they sort of seek from it. Interoception is another area that we've been looking at, and particularly with the work of Kelly Mailer. And for her, interoception, you know, it's quite often referred to as that sort of eighth sense. So we've got our sight, sound, taste, touch, and smell. So they're the five main senses that we have. We've got proprioception and we've got vestibular. So proprioception is, you know, our place in space and time as well too. It's our motor skills, it's our positioning, it's how we do things. And a really good sort of idea about that is, you know, as we grow and develop, we get used to where our physical space is and our physical body is to be able to do a lot of physical actions. And then we hit puberty and everything seems to sort of hit that growth spurt, and we get quite clumsy because we're still trying to attune ourselves back into the fact that we have grown or we're longer and bigger than what we used to be only a short time ago, and that clumsiness that comes with it. Vestibular is your sense of balance, and then the eighth sense is interoception, and that's the sense that sort of allows us to hear our internal body signals. They go up to our brain, and it tells us when we might be feeling a bit hot or a bit cold. It could be when we're feeling aroused, when we need to use the toilet, and those messages are sent up, and from those messages, we interpret what those messages say to tell us what we're feeling and what we're experiencing, and what we need to do, if we need to do anything, to sort of rectify that or to regulate that. So when we notice those sort of body signals, we use them as clues to tell what our emotions are. So what we might find is that when we're in a high aroused state, we know the fight and flight response is a big part of that. And what we find then is that we have a lot of internal messages from inside of our body coming up to our brain that tells us we're in a highly aroused state. So you've got your increase in blood flow, heart rate, increase in oxygen, increase in breathing, pupils are dilating, feeling a bit sort of, you know, a bit sort of warmer on the skin, sweaty palms. We might find that we've got butterflies in our tummy because that blood flow goes from there and into arms and legs, into those muscles. We feel that sense of tension there as well too. And those messages are sent up to the brain. And from that, we're able to work out whether we feel this way because we're excited about something or because we're anxious about something. So then we sort of put the context over the top. Interoception is that internal sensory system in which the internal physical and emotional states of the body are noticed, they're recognized, identified, and then responded to. But also it's that ability to be able to express how we're feeling as well too. We can identify what we're feeling, where we're feeling it, what it means, we've got the vocabulary to go with it, and then we're able to actually express it to others or to be able to resolve it or take actions to meet those needs. So if we're feeling cold, we might do things such as close the window, turn on the heating, put on a jumper. We start to feel too warm from that, and then we might take the jumper off and turn the heating down, for example. So interoception skills are required for a range of basic and more advanced functions, such as knowing when to go to the toilet. And that's the idea of knowing whether it's number one or number two, whether you can hold on or whether you need to go right now as well too. And it's something that we learn and we develop from an infant up into young childhood, where we learn our toilet skills, our toileting skills, and being able to sort of hold on to going to the toilet. And we sort of learn to move from being in, say, nappies, but then into just being able to take ourselves to the toilet. We can also understand when we're starting to feel angry and upset and where that's coming from and what that feels like. But also we're able to find when, not only when we're calm, but when we're becoming calm after being upset or angry as well too. So it's a way of being able to sort of manage our emotions quite proactively as well as reactively. However, some of our children, particularly when we're talking about neurodevelopmental differences or we're talking about learning disabilities, what we might also be talking about there is that difficulties with being able to understand those interoception messages that they're receiving. What do they mean? And that's when we might find that somebody engages in a particular behaviour, exactly the same sort of behaviour when they're upset and distressed as when they're excited and happy as well too. So hopefully that sort of makes sense. A little piece here from Chris Oliver, just to remind ourselves that where we are, genetics, brain development, medical conditions, cognitive profiles, emotional regulation, and the environment each contribute to and interact to cause difficult behaviours in children and young adults with intellectual disabilities. And just to remind ourselves that we have also tackled new areas such as sleep disorders, overeating, repetitive behaviour, and autism and genetic disorders. So we've learned how pain, difficulties with communication, cognitive differences, as well as neurodevelopmental differences, impulsivity, and sensory sensitivity can influence behaviour. Essentially, Professor Oliver is saying that we're learning more and more. We've made great sort of advances, where we've still got a lot more to learn, and we're still on that path and that journey forward. So when I talk about sort of, self-injurious behaviour, from my viewpoint, it can be quite a complex sort of behaviour to sort of work with. There's a lot that goes with it. As we said before, there is no magic bullet. There's no sort of one size fits all. There's no just one single cause, okay? What that means then is that because it is so complex, the way we respond to it is quite complex. And it's usually quite a two-step process. The first part is the assessment, and then the second part from that is management. And management is built upon what we've assessed, what we've been able to learn. But part of that assessment is actually knowing what sort of management strategies, regulation strategies are already in place, and trying to work out what it is that behaviour is actually contributing to that person. What is it they're getting from engaging in self-injurious behaviour? Why is that happening? So some of the causes as well too. One of the things to sort of think about too is that for an individual, sometimes their behaviour seems to be maybe that they're in control of that behaviour. However, for that same person, and maybe with that same sort of behaviour in different situations, they may not be able to be in control of their body, or they may not actually be in control of those behaviours or aware of those sorts of behaviours. So one of the things that we would look at is what sort of awareness do they have of engaging in that self-injurious behaviour? How aware are they? Are they more aware? Are they less aware? And how in control of that behaviour are they? Are they able to stop? So if they're not aware and they're not in control, but if they're made aware, they then become in control. Is that what we might be looking at? Is it a case that even if they are aware they're engaging that behaviour, they don't seem to have control, and they seem to have less control, even when we point that out and we're trying to work with it specifically? What we might also find as well too is that for a lot of individuals, when they're engaging in that self-induced behaviour, they'll actually be less aware of what they're doing, and therefore less in control of that behaviour. So unable to stop once it starts, or so distressed or stressed that they're not actually aware of what they're doing, and that behaviour is becoming quite stereotyped, or getting to be quite repetitive. In which case, then we have to step in, and we might be the ones that need to either intervene or to regulate, to have that behaviour either stop or be able to sort of help that person regulate to the point of where they're actually able to gain control again, if that makes sense. So sorts of things are awareness. How aware is somebody? Are they more in control, or are they less in control, the more aware that they might become of that? And a really good example of that might be someone who is a fingernail biter, bites their fingernails. And that's, once they sort of, are biting, starting to sort of bite their nails, they might be in control of that, but they might actually struggle the more that they're doing it, of actually being less in control, of unable to stop. And then someone else is saying to them, stop biting your nails. That's disgusting. You make them bleed, you make them sore. And that person biting their nails is really, really trying to self-restrain themselves from doing so. But the more aware of the fact that they're restraining themselves, the more that they feel that they need to do it. So the control becomes a lot less. We might have that person might be less aware. So the less aware they are, the less in control. And as a result of that, then being less aware, they're less in control over a period of time. We might find in some cases that actually a person is aware and in control, but the less aware of that, the less in control of that sort of behaviour they may be as well too. So it may be a case of sort of having to do those gentle reminders for that person to be able to then be in control. So it could be someone that's sort of engaging in just, normal little sort of stereotyped or stimming type behaviour. And we've all got them. The toe tapping, the hair flicking, the sort of finger twitching as well too. The little things that we do that we're not really aware of, but are quite regulating for us. But someone points them out and we're actually quite in control. However, we may not notice we're doing them when we're less aware of them. And then, of course, being less in control and less aware in time. So awareness of being not in control of that behaviour, and the more trying to become aware of it, the more difficult it can be. But then when stress or when dysregulation gets to the point where a lot of those sort of cognitive processes and connections are starting to sort of be sort of affected detrimentally, there's less awareness and therefore less control of that behaviour. So they're the classic sort of things where we might be talking about the meltdown, the complete dysregulation, where you've got somebody that has just collapsed to the floor. They're unable to control their motor movements. They're not able to sort of control their balance, crash to the floor, thrashing and kicking, screaming, throwing their arms up and around left and right sort of thing, and then banging maybe their head against the floor as well too, unaware that they're actually causing quite sort of serious injury or bruising to the back of their head. Okay. So we could be testing their awareness. How aware and how in control is that person? How unaware and how out of control that person may be at particular other times, depending on arousal levels, how in control they are when they're less aware of what they're doing. And also, no matter how aware they might be, the less control that they might actually be in as well too. Other considerations to sort of that we take into account when it comes to the assessment side of things. So things like, making sure that there's no medical conditions or physical conditions. Constipation may be a cause of self-injurious behaviour for some people. Migraines as well too, tummy ache, pain, discomfort or illness. Research indicates the typical population for people, migraines run around 20%. 20% of the typical population may have or may suffer from migraines. However, for learning disability and autistic populations, it could be higher. There's a difficulty with self-reporting, and we also know that there is a difficulty and a difference for autistic people versus non-autistic people around sort of pain thresholds as well too. Neurological and sensory differences are linked with causes for self-injurious behaviour. So quite often we really do recommend the inclusion of neurologists or neuro consultants and or an OT. An occupational therapist is quite important as well too, particularly when we might be talking about the sensory side of things or the movement side of things as well too. Difficulties with interoception, okay, communication difficulties as well too. So difficulties in being able to sort of express discomfort and pain and stress. Some of our people that we support, some of our individuals may lack the ability to be able to sort of identify where they're experiencing pain and being able to communicate that to others. Self-injurious behaviour has got links with epilepsy and learning disabilities, and the two of those together increases the risk factors for self-injurious behaviour. And what we have found as well too is that some low-level analgesics, some low-level pain relief can be quite effective in reducing the instances of self-injurious behaviour as well too. So some of the ways of working with self-injurious behaviour, holistic and integrated approach is preferable, okay? So that means that we're taking in all sorts of different factors, looking at all sorts of different approaches, different models, different things, different factors and things that we can do, strategies and approaches, and bringing them together. But we want to integrate them as well too, rather than sort of be doing them separate. Functional analysis assessments are really, really important. So why is that behaviour happening? What's causing it? What needs possibly are sort of being met from that behaviour, but also maybe what's causing some of those behaviours as well too. So you can kind of look at that and we can get a lot of information from that. And that would be through the assessment work, through observation. And part of that sometimes is actually to film episodes can be really important because, as I said before, self-injurious behaviour is quite emotive. So the difficulty sometimes is actually being able to see the bigger picture when you're in the middle of those incidents, and that high emotional state, being in a crisis like that, will have an emotional impact on us as well too. So later on, we can review some of the film and we might be able to see things that we missed by being in it. And some of those things have included some of the cue behaviours that we've sort of seen, anything that might have led up to, prior to that self-injurious behaviour being presented. We can look at some of the sensory factors. So what's that sensory profile like for that person around touch, smell, heat, light, noise? If we think that maybe that self-injurious behaviour has got a communicative function, then we could use a functional communicative training sort of based approaches to maybe provide other ways of creating that communication and being able to have that communication that doesn't involve self-injurious behaviour. The key thing, though, was that we need to develop very clear crisis management strategies. So these crisis management strategies, when that person's engaging in self-injurious behaviour, are very clearly of what we're going to do and how we're going to do it. And it's that level of consistency that's really important. And they need to be documented as well, too. And that's really quite important, because if we haven't got that consistent approach, if we haven't got that documented approach, then we can really struggle to really find out what's working, but also importantly, why that's working when it comes to management. Non-contingent reinforcement. So we're looking at reasons of why that person's engaging in self-injurious behaviour, but there's no contingency to it. It's not linked to anything in particular. So what we might also find from sensory assessments is what sort of sensory domains are positively reinforced to that person that doesn't involve self-injurious behaviour, and which we can then increase and provide more opportunities for those positive reinforcing times, those positive sort of feedbacks, those positive sensory experiences that will actually reduce the need possibly for self-injurious behaviour instead. What we can also do is not just think about doing them at times of when that person's escalating or arousal levels are increasing, or when they're in crisis, but doing them at times when they're quite settled. So we're spreading them throughout the day. And what that means then is that we don't sort of provide these sensory experiences only when that person becomes distressed or upset or anxious. We're providing them at other times when that doesn't happen. So there's no linking to engaging in or likely to engage in self-injurious behaviour, and these sensory experiences, these positive sensory experiences are provided. So we're taking that contingency out as well too. So when it comes to management, proactive strategies, we know that that self-injurious behaviour is very strongly linked with stress and anxiety, triggers, stresses, demands and requests, and all those sorts of things we're looking at reducing, eliminating where we can be, backing off, keeping things a lot sort of simpler as well too. And a key thing with demands and requests is 2 points. Some of them are verbal, the actual words said. So the demand that might be made or the request that might be made, the actual words themselves, but also the fact of actually just talking is a sensory demand and request on that person's sensory system, their sound of audio. What that means then is that when somebody is in that high stress state and they're in that sort of fight or flight zone, their senses, in particular, the three main senses, are going to be hyperactive and hyper alert and hyper receptive to any potential triggers in their environment. And those three are touch, sound, and sight. Okay. So what we're talking about there is if you're reducing those demands and requests, you're reducing those verbal and visual demands on that person. And as a result, then you aren't triggering those hyperactive sort of sensory systems when that person's in a fight or flight type state. What we might be looking at as well too is trying to increase normal regulation strategies. So regulation, and that's where carers need to step in to be able to remove or reduce stresses and triggers. So things that carer can do for the individual to reduce their stress levels. Co-regulation, so when that person's starting to become distressed, what can they do to sort of encourage that person to engage in activities or to engage in other things that helps them to regulate or helps to reduce stress levels. And then the self-regulation, which is the skills that we learn ourselves to be able to self-regulate without someone else needing to do it for us or needing to prompt us to do it along. Looking at some of the protective factors. So what are the factors that actually make a meaningful difference for that person in their lives? Which are the positive factors that actually provide that positive proactive feedback for that person as well too? So what makes them feel good? What are the things that actually reduces or actually sometimes prevents self-injurious behaviour from being presented or engaged in? Increase those positive sensory experiences that we know that person likes and seeks and enjoys. Increase well-being, so things like PERMA, and I'll come to that shortly as well too. Increased sense of well-being increases resilience, increases ability to cope with stresses, better appraisal systems as well too. But also it means that it helps with the ability to be able to regulate and to be able to not be as reactive to stresses and difficulties and challenges that that person might experience. We want to make as many things available that provide that low arousal, okay, and increase calm, reassurance, positive feedback. Distractors and sensory equipment is really important there. And then being able to come up with those management strategies to be able to sort of keep and help support someone to stay at those sort of lower levels of arousal as well. So with PERMA, we're talking about Martin Seligman here. So these are the things that contribute to someone's good sense of well-being. What creates for our people and for ourselves positive emotions, happiness, joy, contentment, settlement. What do they feel like? How do we get them? What sort of things contributes to it? So what sort of things do we engage with? So engaging and interacting with others, but engaging and interacting with meaningful activities, things that create that flow state. And flow state activities are those sorts of activities that we really enjoy and we can get into. And when we're immersed in those sorts of activities, it's the rest of the world, the environment, the world around us tends to sort of fade off into the background. It's those sorts of activities that you do where you find that time just disappears, okay? Getting into those flow state activities creates that flow state that lowers blood pressure, heart rate as well too, and it actually lowers people's baseline, okay? So we're creating more of a lower state of arousal than what that person will normally sort of operate from. Relationships, really, really important for someone's sense of well-being. So those positive relationships, unconditional positive regard, unconditional positive relationships, and relationships, positive ones, are the key things that are going to give someone a key sense of a good sense of well-being. Negative relationships aren't the ones that are going to give and increase that person's sense of well-being. Providing meaning, so the purpose of life, purpose in doing things. What's the point of getting up? What's the point of engaging? What's the point of having those relationships? What's the point of doing things? Okay, that purpose in life. And achievements and accomplishments, big things, little things, all of those things that will actually contribute to someone's sense of self-esteem and self-regard as well too, as well as the regard of others around them, which is really, really important. And altogether, that gives us what we call this health, this sense of well-being. And that's really, really important for people to be able to be more resistant and resilient to difficulties and stresses. And that will also help to reduce the need to engage in self-injurious behaviour. We also need to understand triggers better, okay? We understand that some individuals can self-regulate to a point, and that can sometimes vary from day to day. It can be on situation to situation, and wherever they are as well too. And we have to always remember that just because an individual can self-regulate in one sort of instance or one sort of situation on one particular day doesn't mean they're able to do it every single day. Even for ourselves, we know that we don't always able to cope with the same things from day to day. There's other factors that might be in, and that depends on what sort of resources we've got, what other things might be going on, what other things underneath the surface of that iceberg are floating around there, okay? Some of those external and some internal factors or triggers can push that person over a tipping point. And that's recognizing the fact that some days I can manage, some days it's not a good day to manage as well too. And that's why it's really keen about being able to reduce those demands and requests, those rules and boundaries, and being able to be quite flexible and recognizing that sometimes it's just a matter of backing off might actually be able to help. Having that flexibility to not push today because it's not a good day, but we can do that tomorrow when maybe the day's a bit better as well. Some of the things we're talking about proactively to try and get into our proactive plans is trying to understand not so much why the individual engages in self-injurious behaviour, but why they feel to maybe engage in it. What are the causes? What are the triggers? Why is that person engaging in that behaviour? What is the behaviour achieving for the individual? So what are they getting back from that? So as a result, then we were able to focus in on what are the precursors, what are the things that are actually contributing to either increased stress or actually the likelihood and increased risk factors of that likelihood of a person engaging in self-injurious behaviour. We have to also recognise some of the things that really help. So these are the sorts of things that are the non-low arousal sort of strategies or approaches. Telling the person to stop, again, goes back to that ability to be aware and in control. And if that person is aware that they're not in control, telling them to stop is certainly not going to help, and it's not going to stop that person from engaging in a behaviour they have no control over. And if you've ever had someone in your family that's a nail-biter, you know the more you tell them to stop, the more difficult it is for them not to do it, okay? shouting or raising our voice to a person. And I know that this is something that a lot of us wouldn't do, all of us probably wouldn't do to any sort of degree, but there is times when we have our own moments where we do, in that moment of panic, in that crisis, our voices might raise, okay? We might be trying to make ourselves heard, to make sure that person's aware of what they're doing and trying to stop them as well too. The point is that person is already struggling with dysregulation, and that increase in raised voices will actually communicate not a calming or controlling or helping or supportive manner, but actually contributes to what we call emotional contagion. Your stress from their stress of that behavior that they're engaging in, your stress is sort of on show. From that, they pick up on that. That increases their stress levels, increases that behavior. As a result, we become stressed in return, and it's just that upward cycle of that sort of dynamic feedback of increasing, spiraling sort of stress levels. So we're talking here about using our low arousal approaches and our low arousal skills that we can use. Reactive strategies, again, we're using the low arousal approaches. We're responding to that self-injurious behaviour at that lower level, okay? Quite often what we might find, though, is that that person may actually be sort of giving us some early warning signs that that self-injurious behaviour may actually be coming up. So early reactive interventions are based upon identifying when the person's becoming dysregulated and therefore a bit more likely to engage in self-injurious behaviour. And these are what we call cue behaviours. It's not unusual for some of our individuals to restrain things like sitting on your hands and rocking backwards and forwards, hands up the side of the sleeves, hands inside of the hoodie pockets and stuff like that as well too. Finding other things to engage with. Stereotyped behaviour is a really big one as well too. Something to sort of be able to try and stop that person from actually engaging in self-behaviour would be something that would be sort of self-restraint type behaviours. Early warning signs that this person's becoming dysregulated and they're still in control to a degree, but they're still trying to stop themselves from engaging in that self-injurious behaviour. So what are the cues that have led up to the behaviour? Sometimes with that assessment process, you've got someone that's just observing and they're recording and they're taking some of those notes down. If it's allowed and everyone's given consent, then you can use maybe video recording equipment to be able to look back afterwards and see not just before the behaviour started, but maybe earlier than that, what was in the lead up. There might be some vital clues that we might see. Was there changes in that person's behaviour or their communication? Did that change? Are there any other behavioural cues that we might find? That stimming behaviour, that stereotype behaviour, agitated behaviour, self-restraining type behaviour? Is there anything that person might say or they might vocalise that might give us a clue that they're becoming dysregulated? Do they appear differently? Do they start to behave differently? Is there something a bit, you get that sort of sense of tension from that person, or that they sort of, seem to sort of not be paying attention to what's going on around them? Is there particular triggers? So some low-level behaviours that might indicate that there is some triggers in the environment that are precursors that lead up to self-injurious behaviour. Is there some lower level self-injurious behaviour that person's engaging with that can actually indicate that if this isn't managed or intervened, that could lead on to high levels of self-injurious behaviour? So around those sorts of points, particularly with that sort of reactive, when we're noticing these things, we're looking to distract or divert that person then. So we're looking to intervene as soon as we start to see those cues at the lower level, rather than letting it get up any higher and then trying to intervene where it may not be so successful. For the use of distractors and diverters, they must be powerful sorts of ones. They need to be quite highly motivating, okay? There needs to be the things that we know. It could be the topics that we know that they're really interested in. It could be tactiles, it could be tangibles, it could be food items, it could be activities, okay? They may not always work, may not always be accepted. However, we need to have them on hand. And the key thing about that is that even though that sort of self-injurious behaviour can be quite often be spontaneous and not a planned behaviour, as like self-harm I was talking about earlier, it is kind of expected in a way, as it's a known behaviour. Okay, so we know this person engages in self-injurious behaviour when they become stressed. So therefore, we know that we've got some really strong motivating distractors for that person. We need to have them on hand. And the more that we've got, the more options and opportunities we've got to offer those, and different ways as well too. We're not always relying on the same 1 or 2 or 3 different items. And once they're run out, then we've got nothing else, okay? Equipment use, there's a lot with this, and this sort of comes back to what I was saying a bit earlier about some of the success stories they talk about successfully managing or sort of successful behavioural interventions used. But sometimes using them doesn't actually, the use of them doesn't actually work based on what we think, the assumption of why that has worked. There could be some other reasons. I know that sounds a bit confusing, but bear with me. The effectiveness of some of these. So head guards solve superficial injury or damage. However, what we don't sort of think about there is sort of the internal, the microconcussive damage that's still going on. That person's still engaging with headbanging against a hard object. And sure, it's protected on the outside possibly. However, what we're finding is that the brain inside the brain inside the skull is still moving. So you've got that sort of concussive factor, that bruising on the brain, both front and back. And we've spoken a lot about the effects of that for people that play rugby and football, particularly at a professional level or over a long period of time, okay? However, using those sorts of head guards and those sort of head protections, is it working because of the sensory feedback the pressure provides? We give that person the head guard, they place it on, and we've noticed that the self-injurious behaviour either decreases or it stops completely when that person's wearing a head guard. Is it because that is actually providing them with protection from hitting their head, or is it a sensory feedback that we're getting as well too? Okay. What we may also find is that with the head guard on, that sensory feedback that person's looking for is such that they're not getting it because it's muffled with a head guard on, which then causes that person to hit their head with a greater force to get that same stimulation. Externally, the damage might still be protected by the head guard, but now we've got even greater impact on the brain inside the skull. So the other thing too is that we've got two options. Are we only using the equipment when the behaviour occurs? In which case, is it because we're putting the head guard on that's actually stopping the behaviour? Or is it the simple fact that we're just actually interacting with somebody that actually reduces or helps to stop that self-injurious behaviour? So what is the contingent and why is that sort of working would be one of the questions. There is some dangers and concerns around the use of equipment for long periods of time. At some point, we need to remove those head guards or those sorts of equipment, protective equipment. And if we're going to, what's going to happen? Okay. It's only supposed to be a short-term response. We don't want people to spend the rest of their lives in a head guard. We need to have a plan to remove them. So one of the examples that we had was hand splints. It was a young man, and I mean young man, he was in his early 20s. He engaged in sort of head-banging self-injurious behaviour. And the service that he was at had actually then put arm splints on. So they're sort of a padded arm splints, so arm sort of pieces of equipment goes over the arms. It's got a splint through the centre. So essentially, then instead of being able to bend your elbows, it keeps the arms straight. So it stops that person from being able to hit themselves when they bend their elbows. It didn't work because instead of being able to bend his elbows, he was hitting his head off the side. And as a result of that, he was still engaging in self-injurious behaviour. There was concerns about damage to his retina. And as a result of that, and this is going back some years ago, but what they had implemented then was the use of a Velcro belt that went around his waist and effectively pinned his arms straight as they were against the sides of his body. When we became involved, the difficulty had been is that his need to still engage in that self-injurious behaviour had resulted in him finding a way of being able to sit down and using his knee to continue that behaviour. And he was kneeing himself in the head. And this was obviously causing further higher risk, extremely high, significant risk of brain damage, of injury to the brain and to his head, and especially to that orbital area and possible retinal detachment. What we did find from that is that through some of the sensory assessment is that it was interaction, but also there was a sensory feedback that sort of he was getting from that initial self-injurious behaviour he was engaging in. So what we did over a period of time with that is we had 2 staff members, and it was throughout the day, every 20 minutes for a few minutes at a time, staff members, one on one side, one on the other, would take the arm splints off. And the moment they took those arm splints off, he would start to raise his hand, and staff would just bring his arms back down and they use a massaging on either side sort of thing. So a bit of sensory feedback. And whether he was relaxed, whether he was a bit agitated, or whether he was really quite distressed, it didn't matter. It was always used. There was no contingency that only when you're upset do you get this arm massage. It was used all the time. Over a period of time, those arm splints got shorter and shorter. They turned into padded gloves. And it was the sensory feedback he was getting from it that actually changed over time. He was getting it from the padded gloves rather than the pads on the arm splints that he had. And then it got to the point of where he got down to just having sweatbands, wristbands on either side sort of thing. And it was the pressure from both of those was giving him that sensory feedback. But staff was still engaged with sitting either side of him to give him an arm massage. And even when they took the sweatbands off, his hands would still come up to his head, but he would be getting the arm massage from staff either side. And it's quite a complicated case, but that works. And we knew that worked because in the early days when we introduced it, he was looking forward to and he sought out having that sort of massaging on his arms from staff as well too, to the point of when he would sit down with his arms out and his wristbands on, he'd be laughing and smiling. And as soon as staff sort of took them off and engaged them, you could really see he was getting some really good positive feedback from it. That's just one of those cases. And again, it's one of those where the intervention had positive outcomes. Reducing a self-injurious behaviour may increase stereotype or other sorts of behaviours. So you may need to put up with maybe physical aggression. You may need to tolerate physical aggression, verbal aggression. You may be looking at having to tolerate increases in property damage or absconding, any of those other sorts of behaviours, stereotype, stemming type behaviours as well too. But that may be because self-injurious behaviour is actually reducing. And that's what we're looking to do, because we can then work with other areas of being able to sort of manage, tolerate, and maybe over time change some of those behaviours as well, while maintaining that reduced self-injurious behaviour. Use of equipment is quite a short-term consideration, okay? So we can use that sometimes while we try to work out what is causing that self-injurious behaviour and what sort of proactive strategies and approaches we can do and put in place to actually reduce the likelihood and the risk of that person engaging. However, we know as well too that we may get some long-term issues may arise if we're using that use of equipment into a longer-term sort of prospect as well too. So we may actually be creating other areas of difficulty that we'll also need to manage. So protective headgear can be quite controversial. We know that most self-injurious behaviour tends to be episodic. However, sometimes we find individuals have got that protective headgear or those arm splints on for long periods of time. So even when the person's no longer in crisis, or even when they're not in a high state of arousal, they've still got those protective materials on. So we have to make sure that that person not only doesn't have the protective equipment on at all times, but even when that person's in crisis, that we don't always use protective materials, so we don't make that contingent link between using protective equipment and when that person's in crisis as well. Some of the protective equipment, mechanical and physical restraints can be positively reinforcing. Some people might actually be looking to get that mechanical restraint or seeking to be held as a way of being restrained from, rather than being able to self-restrain themselves, they're seeking others to restrain them, to stop them from engaging in that sort of behaviour. Okay. So what we might find is sometimes that headgear might provide that sort of deep pressure contact, which provides that sense of a restraint or that sort of idea of being held, that sort of pressure feedback. And as a result, that person may actually be looking for some of these mechanical or protective equipment type pieces of items to be used and to be applied. We need to also make sure that some of that age-appropriate protective headgear can be used. So, where we are using that, is there anything else that we can do differently? And that other example I gave you beforehand of the arm splints, for that young man in his 20s to be able to go out in public having his arms in arm splints that have been essentially Velcro belted to his sides, wasn't a particularly good look, wasn't a very particular respectful look for him to go out in public looking like that. However, over time, having sweatbands on, he was able to not engage in self-injurious behaviour because the sweatbands were giving him that pressure feedback he was looking for, but they look quite normative as well too. So a lot more appropriate for when he was out in the community. Some of the ones we have seen is sort of things like a protective bandana, which gives that person that sort of sensory feedback, strong sensory feedback of deep pressure around the head area, but it's in the style of a bandana. So it doesn't look too out of norm, okay? Low arousal approach itself, so we can be looking at some of the sorts of things that we want to do around distraction, diversion, and what sort of low arousal things can we be doing to help to decrease that person's arousal levels, or at least prevent them from going up in arousal as well too. So we need to think about our non-verbal communication, the things that we might do. And these are the 10 non-verbal low arousal strategies. The idea of being calm, staying calm and appearing calm, not having that emotional contagion. So our stress isn't picked up by the person already stressed, which increases their stress levels and then can lead on to some of those behaviours that we then might need to manage. Avoiding direct eye contact is highly arousing, so not staring at that person. Being careful about physical touch. I said before that when we're in that high fight or flight type response, when we're in that high arousal state like that, our senses are hyper alert, which is our visual sense, sense of touch, and a sense of sound as well too. So being very, very wary about how we use physical touch and what sort of response that might get from that person. So just knowing that you can hug some people and some people you can't. Slowing our movements down is the visual side of things. Okay, so that person's already hyper alert for threats in their environment. Someone moving fast, quickly, in an agitated sort of stress state, trying to intervene very quickly, means then that that person who is in a high arousal state perceives those threats a lot more because of those fast movements around them. Be aware some of the gestures that we can be misinterpreted. So what is our body language giving off? What is our facial expressions? What sort of things are we saying or doing that can be misinterpreted in a different way? Removing the crowds of people, okay? So either removing extra staff or stopping them from gathering when there's a crisis. One person is supporting and managing, maybe someone else is nearby. Within the earshot, if that first staff member or carer might need support, okay? But not having a load of staff gathering around who will all be looking, possibly not getting there calmly, certainly not moving slowly to get to that sort of room wherever anything is happening. And also for that individual, it's gone from one member of staff to maybe 2 or 3 present. That increases the risk of physical touch, i.e. increases the risk of restraint. Removing other people from the situation, again, takes a lot of that crowd out of it as well. So getting rid of the rubberneck side of things, keeping your distance, providing that person with some extra space to be able to feel safe, that they're not going to be at risk of being restrained, but also just giving them that extra space that they need when they're in that high arousal state. Again, the power messages. So what sort of things are we doing? How do we present ourselves? The crossed arms, the keys that might be hanging from the belt sort of thing. The stern look, the command in our voice as well too. Or just the fact that we've got 3 or 4 staff members could be quite intimidating for somebody, and that could be seen as coercive when we're making some of those demands and requests and asking someone to stop what they're doing or to move to another room, and then backing off, that tactical withdrawing from the person. And a lot of these things we talk about with the low arousal strategies and the low arousal webinars that we do. And we've got some of those. We've got the foundation course, which focuses very much on low arousal approaches. And then we've got the advanced course that uses that and then moves into stress and trauma as well too. So personal space, eye contact, touch, noise, removing others, really important. Communication, keeping it simple, okay? The non-verbal communication as well too. Sometimes the visual communication, we're not saying a word. So things like, pointing to a door or holding the door open rather than asking that person, do you want to go outside? And then communication for us is listening to what that person is saying, but also listening to what their behaviour is communicating to us. Distracting, debriefing, talking, and recording. Some of the active strategies, these are the things when all else fails. So keeping that person safe. What do we do in that moment to keep everyone safe, to get through that moment as quickly and as safely as possible? From that, we can then, once we've gotten through to that other side, we can look back, have a reflective piece of time, strengthen our proactive and reactive strategies, try to sort of look at what's happening in the environment, what's contributing to that person's stress, or what could be contributing through demands, requests, other things going on, sensory sort of systems as well too, to be able to better identify and respond to those triggers or stresses that causes that person to start to become distressed and dysregulated. So what can we learn from those moments when we get through to the other side? What worked well, what didn't work, and what do we need to do differently next time? We can use movement, okay? So we can alter the nature of our self-injurious behaviour by actually bringing in movement. So rather than it being the sensory feedback of hitting that person, for that person that they're engaging in self-injurious behaviour and that feedback, we might be able to sort of change that and turn it into more of a glancing. Contact still made, the impact's a lot less. But by doing that, we can get that movement and a bit of rhythm into it, use that sort of stereotype, sort of routine, regulatory sort of movement behaviours, and we can add in some positive things. We can add in some nursery rhymes or some singing or movement. And then over time, the movement and that sort of engagement is what that person's seeking, not the physical contact from hurting themselves or hitting themselves they're looking for. Can help to reduce the intensity of some of that self-injurious behaviour. We can change the feedback, so we can change contact to the movement, as I just said. So going from hitting myself to maybe row, row, row the boat, or Thomas the Tank Engine type thing. It could be the interaction feedback. So me singing those nursery rhymes, smiling, enjoying, using a very calm approach to actually sort of create a positive sense of feeling from doing something slightly different that over time I can develop into something very different from the initial self-injurious behaviour. Also, it can be that engagement feedback. So the difficulty sometimes when someone's engaging with hitting a wall with their head, and we're trying to put something in there to block, to actually take some of that padding off, to sort of take off some of that injury or the risk of injury. What we might do then, particularly if that individual is trying to move that away and still engage in that sort of head hitting onto a wall or a hard object, is that we can actually sort of maybe move the target. And then that becomes the focus for that person. They're more focused on the movement of that. And as a result, then they're not trying to remove it, but then maybe it's creating some of that padding, or we're changing the nature of that sort of behaviour as well too over time. So change the behaviour itself is another alternative, longer term, alternative ways to have their needs met, to gain that sensory stimulus. So going back to that sensory menu as well, to have that interaction and communication with others, and to reduce any sort of negative sensory experiences in their environment. So that feeds back into our proactive plans and strategies as well. Recognizing that the actual behaviour itself is going to have a big emotional impact on people, on carers. So, you know, for staff, for carers, professional carers and staff, how do you debrief? Ensuring that you're debriefing to be able to look after yourself and be able to release that emotion, to resolve those moments, to be able to resolve those experiences, as traumatic as they are, to be able to be better prepared and able to cope with moving forward with plans and strategies, and just being able to support that person going forward. For carers at home, who is it you talk to? Who do you actually be able to sort of unload that emotion with, to pack that away and resolve it, and then be able to sort of recharge yourself for the next point of caring as well too. It's about supporting ourselves, looking after ourselves, but also supporting and looking after each other. And then that post-incident recovery. So after that, how do we maintain our positive relationships with that person? So this feeds into PERMA, okay? Those positive emotions, but also the relationships as well too. That unconditional positive regard, those positive relationships. Developing longer-term therapeutic interventions. So what have we learned reflectively from what's happened and from what we're continuing to do to actually get a better supports and strategies and have longer-term, more therapeutic and more effective interventions, better management tools. Develop anything that might be organisational, that can be at home, that can be also in service providers and service provisions. What can we do that will be able to support? And we talk about extra training, extra staff, respite for carers and for parents at home, providing additional sort of support workers where it's needed as well too. So what are the organisational responses that we can do? And then designing environments from a low arousal perspective to reduce that person's baseline, but also reduce the stresses as well too. So a lot of my recent work with individuals that do present with self-injurious behaviour has focused a lot on sensory assessments, okay? Sound sensitivity has been a common exasperating factor for a lot of the individuals I've worked with. So what that has meant is that I have focused quite a bit on actually what are the sensory factors that are involved, and either preventing the protective factors that prevent the person getting to that arousal state where they might engage in self-injurious behaviour, and what are the things that are actually cause them to get into that high arousal state, which may actually put them at risk of engaging in self-injurious behaviour. And then I'm working on that to increase one and reduce another as well too, okay? And it's providing a lot of those good sensory reinforcers, the positive reinforcers, the positive sensory experiences, the positive sensory distractors, motivators as well too. It's part of a sensory diet, but I want to make sure that they're non-contingent. So I'm not just going to use them when that person becomes stressed or distressed. I'm not going to use them when they're in crisis and engaging in self-injurious behaviour just then. I'm going to use them all the time, and I'm going to vary them up. So the more I've got, the better I'm able to sort of spread them out. And I'll be using at times when they're quite calm and relaxed and they don't need that intervention, but I'll do that anyway to ensure that there actually isn't any sort of connection, contingent reinforcement connection between the engagement and the sensory reinforcers or positive experiences I'm using and what their stress or arousal levels might be at as well too. A bit of further information there before I move to the question and answers is that we are producing some practitioner articles on self-injurious behaviour in the near future. They will cover both the assessment side of things, but also management strategies and how we can develop some of those sorts of support plans. And also, you know, if you use further information or anything around sort of maybe consultations for any of the people that might be in your service or for families, please get in contact and we can sort of have a talk and see what we can provide around assessments, management strategies or support plans as well.